Now, in ectopic pregnancy, okay, from where the term, okay, is derived. So this is derived from the Greek word, which is known as ectopos. Ectopos means out of the place. So in this condition, the implantation occurs out of the normal site or the normal place. That's why it is known as ectopic pregnancy. The gestation grows and draws its blood supply from the site of abnormal implantation. It can happen even in the abdominal pregnancy from the nearby organ or the structure, the implanted egg, it can derive the blood supply. As the gestation enlarges, it creates, see there, it creates the potential for organ rupture because only the uterine cavity is designed to expand and accommodate the fetal development. The extra uterine site cannot do that, importantly fallopian tube. It doesn't have enough space there to accommodate the fetal development, a rapidly growing embryo. So after a certain time, it will rupture. That rupture can lead to massive hemorrhage and can even lead to death because of hypovolemic shock. If that lady survives, okay, then later on, as a result of treatment, she may suffer from infertility because the treatment of ectopic pregnancy is usually salpingectomy or salpingostomy. So there will be either loss of the fallopian tube, or some fibrous reaction or some scarring because of the surgery that can lead to occlusion of the tubes. So after that, she may suffer from infertility. Let's move on. Now, non-tubal ectopic pregnancies, okay, are a rare occurrence. Non-tubal means outside the fallopian tube. Remember, the majority of the percentage, almost 98%, occur in the fallopian tube. With abdominal pregnancy accounting for almost 1.4% of the ectopic pregnancy, and ovarian and cervical site account for another 0.2% each. Okay, so 98% belongs to the tubal one, and other 2% belong to some other area. So that is an easy way to remember. Some of the lady even present with abdominal pregnancy. Okay, and it is difficult to diagnose in the beginning. Remember that, because it almost looks like the baby is growing there, just like inside the uterus. Okay, but that baby cannot survive till the full term. The baby probably, this pregnancy manifests somehow towards the middle of the pregnancy. A lot of complication can occur there. The amount of, blood flow to that baby is never enough, like inside the intrauterine pregnancy. Ectopic pregnancy of the cervix in previous cesarean delivery scar or in a rudimentary uterine horn are all part of ectopic pregnancy. But somebody may argue these are the site of the uterus itself, so why are they called ectopic pregnancy? And the answer is only the normal uterine cavity is the preferred site for implantation. The body of the uterus put towards the posterior wall is the preferred site for the implantation. Apart from there, even inside the uterus, if it occurs in the cervix, okay, in the uterine horn, okay, or even in the scar area, because of the previous cesarean section, all of them are considered the part of ectopic pregnancy because they are not normal. Now, before we move further, okay, this is a very important question from the exam point of view. What are the differential diagnosis of ectopic pregnancy? What are the situations where we often confused between ectopic pregnancy and some other condition? One of them is threatened abortion. Now, tell me, what is threatened abortion? What do you mean by that? Anyone? Who can answer that? What is threatened abortion? Anybody?
So threatened abortion, like said, is basically like said, it's not the real abortion. So we have got like before the 20 week of pregnancy, we've got some sort of vaginal bleeding or like internal bleeding. So and so, but it's not basically abortion. So just like sort of that
Okay. Yeah, your answer is there. Threatened abortion, okay, is the pregnancy is threatening to discontinue, but it has not yet, discontinued. It is threatening to do so. It is threatening to abort. That is not a threatened abortion. Till now, okay, it is not irreversible. So if we identify this in time and apply the appropriate treatment or provide the appropriate treatment, then the pregnancy may continue. That is called threatened abortion. Now, two important points you should always remember here are: one is the duration. It should occur prior to 20 weeks of gestation. Prior means before 20 weeks of gestation. And another one, if we examine the cervix, is it open or is it still closed? Yes, the cervix. What is the answer? Is it open or is it still closed?
Close, sir.
Close.
Absolutely, it should be closed. Then only the definition of threatened abortion will be fulfilled. Okay, never forget these 2 points. The lady will have some spotting or some vaginal bleeding. That's why we are considering the differential diagnosis here. She may have some crampy abdominal pain. Okay, but when we examine, the cervix is still closed, and okay, the duration of the pregnancy or the gestational age should be prior to 20 weeks. This is called threatened abortion. Another is called incomplete abortion. Incomplete. In this condition, the cervical os is already open now. Some of the product of conceptus, we call it POC, have already come out, but something is still left behind in the uterine cavity. That's why we call it incomplete type of abortion. So it is also considered as one of the differential diagnosis because of the bleeding. Okay, because something is coming downwards. Okay, now ectopic pregnancy, that's why we are talking about this now. Okay, so you don't need to include this in the list because this is the differential diagnosis of ectopic pregnancy. But sometimes what the question will be like, what are the causes of bleeding in early pregnancy, or what are the differential diagnosis of bleeding in early pregnancy? If the question is asked like that, then you don't forget about the ectopic pregnancy. Okay, that's why this is included here. But if they ask you what are the differential diagnosis of ectopic pregnancy, you don't need to mention it because we are already covered that. Another one is hydatidiform mole, also known as molar pregnancy. I have not taken a class about it. I will include this in gynecology. Okay, we have enough time to cover that. This is the formation of grape-like structures or clusters inside the intrauterine cavity. Apart from the normal fetal tissue, those grape-like structures will be formed. Okay, this is known as hydatidiform mole. Complete mole and incomplete mole. They are mainly of 2 types. And this can also result in a vaginal bleeding. In a reproductive age woman with abnormal vaginal bleeding, the possibility of pregnancy or complication of pregnancy should always be considered. So sometimes even the implantation bleeding can happen, which is considered a bit of normal thing. Okay, so rule out pregnancy first and then think about some other thing. Now, the important part of today's lecture is etiology. Why ectopic pregnancy occur? What are the causes? So please pay attention here. The most important point is a tubal damage. That is fallopian tube damage is an important cause of ectopic pregnancy. This can be the result of infection such as pelvic inflammatory disease, which we have just talked about, or salpingitis, whether documented or not. Documented means diagnosed, but sometimes it is asymptomatic as well, or can result from abdominal surgery or tubal ligation as a part of tubectomy, as a part of permanent contraception or sterilization, you can say, or from maternal in utero diethylstilbestrol exposure. This is a type of estrogen, diethylstilbestrol. And long time ago, many of the pregnant ladies, they got this long time ago, probably in 1970s. During that time, So after that, many of the babies who were delivered later on, they develop a lot of problem in the fallopian tube, and they also develop vulvar carcinoma. So these are the important questions from the MCQ point of view. Diethylstilbestrol exposure during pregnancy, can result in vulval carcinoma later on in that baby when that baby grows older. We really do not know what is the mechanism there, but this diethylstilbestrol, these days it is not used. Okay, it is a matter of the past, but it's still important, question in the exam. So what is the lesson learned here? By any means, if fallopian tube is damaged, it can result in obstruction or the scar tissue formation. That is an important cause of ectopic pregnancy, just like infertility. History of previous ectopic pregnancy. Overall, a patient with a previous ectopic pregnancy has 50 to 80% chance of having a subsequent intrauterine gestation and a 10 to 25% chance of future tubal pregnancy. See this. Not all of them who have previous ectopic pregnancy will again have a tubal pregnancy. The chance is less. 50 to 80% of them will have a normal intrauterine gestation, but around 10 to 25% of them can have a future tubal pregnancy. So there is a chance. So good history has to be asked. Now, smoking itself is a risk factor for tubal pregnancy. And the reason is that smoking will damage the cilia, okay, in the fallopian tube. These cilia have got a very important role to play because that fertilized ovum should move towards the uterine cavity after it is fertilized. If that cannot happen, and if it is implanted in the fallopian tube itself, that is called ectopic pregnancy. Okay, so once it cannot move towards the uterine cavity because of the damage of the cilia, it can implant there, and smoking contributes in that process. Now, another one is altered tubal motility. See here, altered tubal motility. As mentioned, this can result from smoking. We just talked about this, but it can also occur as a result of hormonal contraception, progesterone only contraception, and progesterone intrauterine device. Okay, they are associated with altered tubal motility. Remember, progesterone is the hormone which is a relaxing type of hormone. It relaxes everything, just like in the GI tract. In GI tract, it can lead to constipation because of the relaxation of the GI tract, because of the abolition of the peristaltic type of movement. So similar type of mechanism occurs in fallopian tube as well. History of 2 or more years of infertility. Okay, now after that, if the lady becomes pregnant again, then there is a chance of ectopic pregnancy. See there, women using assisted reproduction seem to have a double risk of ectopic pregnancy, that is up to 4%, although this is mostly due to the underlying infertility. What is the cause of infertility? It depends on that. The types of assisted reproduction technique are in vitro fertilization or gamete intrafallopian transfer. Okay, these are the type. We have recently done that topic of infertility. So these are the different terms which we mentioned there. In vitro fertilization means sperm and ovum both are obtained from each of the partner, and they are fused, okay, together outside the female body in the lab, and then that zygote will be implanted. Now, one of the way of implantation of that zygote is inside the fallopian tube itself, and then after certain time, that zygote or gamete will slowly move towards the intrauterine cavity or uterine cavity. That's what we expect. But sometimes it may not happen like that. It will implant right there, and it will not move towards the uterine cavity, and that is known as ectopic pregnancy. Now, another etiology may be history of multiple sexual partner. Now, what is the link between history of multiple sexual partner and ectopic pregnancy? Anybody? What is the link there? What may be the process involved here? That is sexual.
Multiple sex.
Exactly. Multiple sex partners. If the lady is indulging sex with multiple sex partner, then there is a high chance of pelvic inflammatory disease or sexually transmitted disease. Now, just now we have talked about pelvic inflammatory disease or sexually transmitted disease is highly associated with salpingitis and damage of the fallopian tube. And damage of the fallopian tube is related with infertility as well as ectopic pregnancy. So that is the linking mechanism there. Another important point is the maternal age. Now see here, there is progressive loss of myoelectrical activity in the fallopian tube because of aging process. So if the lady becomes mother after the age of 35 or after the age of 40 or even beyond that, till there is no menopause, she can become pregnant. Okay, theoretically, it's a possibility. But there is an increasing chance of a lot of congenital anomaly along with ectopic pregnancy as well, because those fallopian tube, they do not contract that much. Okay, and they cannot push that fertilized egg into the uterine cavity. This is known as loss of myoelectrical activity. Another point which was already discussed is diethyl stilbestrol exposure, DES. Okay, diethyl stilbestrol. It's a type of estrogen. In utero, exposure of woman to diethyl stilbestrol is associated with a high lifetime risk of broad spectrum of adverse health outcome like infertility, spontaneous abortion, and even ectopic pregnancy. But this is a matter of past. This is just a historical importance these days. Nobody would prescribe diethyl stilbestrol these days. Now, what are the other factors apart from them? See here, they are also importantly asked in the exam, okay, in the different form of the paper or question. Other risk factors associated with increased incidence of ectopic pregnancy include anatomical abnormalities of the uterus, such as a T-shaped or bicornuate uterus. Okay, these are some of the congenital or anatomical abnormality which are already there from the time of birth. So if there is implantation inside one of the cornu of the uterus, it is still considered as ectopic pregnancy because this is not a normal site. Fibroid or other uterine tumor can result in ectopic pregnancy. Now, what is the mechanism? Fibroid are of different type. Okay, it is intramural type, submucosal type, and subserosal type. Now remember, any of those type, if they are blocking the opening, okay, of fallopian tube, then that fertilized ovum or the zygote is relatively big in size, isn't it? So it cannot pass into the uterine cavity. But the passage of the sperm may not be obstructed. That's why she still can become pregnant. But the passage of that fertilized egg is a problem because of the size. And that can result in ectopic pregnancy. Previous abdominal surgery can lead to adhesion. Those adhesion will lead to kinking of the fallopian tube. So that may be the cause of ectopic pregnancy there. Failure with progestin-only contraception, okay, and ruptured appendix again leads to adhesions. So all of these are important causes. Now, let's move on to the very important part of today's lecture. What are the clinical presentation? If that type of lady comes to us, how we diagnose, how we suspect, isn't it? First is the suspicion, then only we can diagnose. So let's talk about the symptoms first, and then we will move on to the sign. The classical clinical triad of ectopic pregnancy is pain, okay, lower abdominal pain, amenorrhea, and vaginal bleeding. Now, Unfortunately, only about 50% of the patient present with all these three symptoms together. Pain, amenorrhea, and vaginal bleeding. If this happens in the first trimester, and that is also very early in the first trimester, she may have just missed one of the period, okay, then this is highly suggestive of ectopic pregnancy. Remember, why early in the pregnancy? Why it doesn't manifest in the late first trimester? Why in the early first trimester? Anybody? Why so?
So due
Sir,
to the
because
effect of the
Yes, please, one by one. Yeah, both of you, one by one. Yes, I'm listening. Yes, Irfan.
sir, due to the normal effect of the progesterone, which is produced by the corpus luteum, and when the time passed, the progesterone produced by the corpus luteum decreased, and sir, there is no proper development of the placenta. That's why, sir, there is bleeding.
Yes, another answer, please. Yes, I'm listening. Please go on. Now, did you get my question here? The question is, why ectopic pregnancy manifests so early? Why not probably like 10th or 12th week or even beyond that? Why not? Why so early, like 6 to 8 week or 8 to 10? Okay. Okay, somebody is causing a lot of disturbance. Okay, now Shihar, the answer is very easy. The answer is a little bit tricky though. Okay, just use your common sense. Where it is implanted in the fallopian tube. The size of that fallopian tube is not that much. Remember, so it can never reach that big size at all. It will manifest early. Our goal is to diagnose it before it ruptures. That is the goal. If you want to treat it easily, in the easy possible way, without any complication development, we should be able to diagnose before it gets ruptured. But many of the time it is not possible, because when the lady comes to the hospital, it is already ruptured. So these are the important points, and that rupture occurs quite early, because just think about how big is the fallopian tube. It's very, very small caliber. So the massive enlargement of that zygote is happening, or the embryo at that time, I should say embryo, is happening. So it cannot accommodate that embryo for a longer time. It will rupture quite early. About 40 to 50% of the patient with an ectopic pregnancy present with vaginal bleeding. 50% have a palpable adnexal mass, and 75% may have abdominal tenderness. So all those three features together may not be present in every woman who are having ectopic pregnancy. Some of them may only have vaginal bleeding. Some other may have palpable adnexal mass, or some other may have abdominal tenderness. But if all three things occur together, then the diagnosis will be very easy. Now, let's move on. This is a very interesting topic. Patients may present with other symptoms common to early pregnancy, and those symptoms of early pregnancy are nausea. Okay, nausea. This is known as morning sickness. Is it not? Morning sickness, very common term we use for features of early pregnancy. Breast fullness or breast engorgement, fatigue, low abdominal pain, heavy cramping type of pain, shoulder pain, and even recent dyspareunia. Okay, this shoulder pain is a vague type of pain, and dyspareunia. So all of these may be non-specific, because they are present even in normal pregnancy, and they are present in ectopic pregnancy as well. So both are a pregnant condition. Remember, the gravida is positive in both of them. But here, the implantation is the main problem. Painful fetal movement in the case of advanced abdominal pregnancy, dizziness or weakness, vomiting, syncope, or even cardiac arrest have also been reported. They are all the features of complication. Features of complication. A fetal, implantation is occurring in the abdominal cavity, and that fetal becomes bigger, and it may reach in the second trimester. Then the fetus start to move. So there will be painful fetal movement because there is no barrier now. There is no uterine, barrier. The baby is directly present in the abdominal cavity. Okay, so the movement can be felt, and that is quite uncomfortable. That is the point. Second one, it may bleed, it may rupture. All of that may be associated with hypovolemia, hypovolemic shock, and all other complications. Shoulder pain may be reflective of peritoneal irritation, only present in complication, not before that. Okay, remember in surgery you have studied recently, left-sided shoulder pain, okay, may occur in a bleeding in that area, which mainly occurs after the spleen rupture. It's a similar type of situation, though here spleen rupture has not occurred, but there is bleeding inside the peritoneal cavity. So if we elevate the lower part of the, lower part of the body of the patient, then the blood may trickle and it may irritate the diaphragm there, which may result in a shoulder pain. Let's move on. Clinicians should have a high index of suspicion for ectopic pregnancy in any woman who present with this symptom and who present with physical findings of pelvic tenderness, enlarged uterus, adnexal mass, or tenderness. Now, one simple question I like to ask you. In this situation, the implantation is occurring outside the uterus, but still uterus is enlarged in size. Why? What is the mechanism? Anyone? Why uterus is enlarged here?
Sir, because of adnexal mass.
Yes.
Any other answer? Yes. Other students can also, speak here. Anybody?
So because of the hormones.
Because of the hormone. Good. So can you elaborate a little bit what type of hormone and from where these hormones are released? Yes.
Sir, in the ectopic pregnancy, sir, there maybe sir, palm the syncytial tubulast will produce the HCG and produce the progesterone, will increase the size of the uterus.
Good. Now the points are coming. Very nice. Now listen here. Okay, this is a bit of tricky type of question, but it is not very difficult to answer. This is also a type of pregnancy. There is also implantation going on, and here is also synthesis of the hormones. But the level of those hormones are lesser than in the normal pregnancy. Okay, but still there is a presence of the hormone, and the effect of those hormone regarding the uterus is, remember, a secretory endometrium. Okay, there is a hypertrophy of the size of the uterus, and all those things are occurring because the effect of progesterone there. Estrogen is also present in that condition, though the level is less, already talked about. That is the reason for enlarged uterus. But this enlarged uterus is never the size of normal pregnancy. It is just enlarged. This is an important question asked by many teachers in the exam. Adnexal mass will be there. There is no worry, point regarding that, because there is a implantation in the fallopian tube. So adnexal mass will form. Okay. But my question is, what is the cause of enlargement of the uterus itself? And that is because of the hormone. Approximately 20% of the patients with ectopic pregnancy are hemodynamically compromised. Now, this is because of the rupture. See there. Hemodynamically compromised at initial presentation, around 20% of the patient, which is highly suggestive of rupture. Fortunately, using modern diagnostic technique, most ectopic pregnancy may be diagnosed before the rupture, and this is our goal. This has to be the goal. Okay, so how it is diagnosed now? It is diagnosed with a good antenatal checkup. The lady, after she misses, okay, the menstrual period, she has to report to the obstetrician and go for the examination. Or if she doesn't want to go during that time, if she develops some warning symptoms and sign, like a bit of a more type of crampy pain in the lower abdomen, still there is no rupture, remember that, but crampy pain may be felt there, and these things she should go to the hospital and diagnose. But it all depends on her. If she doesn't go, and by the time she comes to the hospital, if it already rupture occur, now that is a late type of presentation, and that is a very, very detrimental situation for her survival as well. If diagnosis is not made in time, even at this stage now, she may die. Let's move on. Now, as a doctor, okay, during physical examination, what physical findings we will get there? Now see here. Presence of peritoneal sign is one of them, because the bleeding in the pelvic cavity. Cervical motion tenderness is another one. When we move the cervix during our bimanual examination, there will be tenderness felt. And there may be unilateral or bilateral abdominal or pelvic tenderness. Okay, usually much worse on the affected side. Where is the implantation occurring? Where is the ectopic pregnancy growing on that side? There will be more tenderness. So these are important physical examination findings. Now, some more. Abdominal rigidity or involuntary guarding and severe tenderness, as well as evidence of hypovolemic shock, such as orthostatic blood pressure change and tachycardia, should alert the clinician to a surgical emergency, and this may occur in up to 20% of the cases. Now, throughout so many surgical discussion and so many other clinical discussion, we have been talking about what are the clinical feature of internal hemorrhage. Okay, once again, very recently we talked about that, but once again I like to highlight those important points. Many of the time we cannot see the bleeding externally, but the bleeding is going on inside. So the first sign of that is tachycardia. Okay, tachycardia. She is not febrile. She's not having any other infection in the body. And we should ask the question, why is she tachycardic like this? Try to find out the cause. Think about it. Okay. And when we take the history, she may say, doctor, I missed my first period. Okay. I mean, last menstrual period. Okay. We should ask about that and ask when during taking this history, she said, I just missed my period. Then suddenly the reason may strike. Yes, she may have an ectopic pregnancy. It may have ruptured. Okay, so that type of thinking should be there. That's what I mean here. Then, if the bleeding is very severe, she should have low volume pulse. Okay, she may be having decreased blood pressure, prolonged capillary refill time, quite cold and clammy type of periphery. She may look pale. There may be excessive sweating. There may be decreased urine output. So many different features are there. However, the midline abdominal tenderness or a uterine size of greater than 8 weeks on pelvic examination decreases the risk of ectopic pregnancy. Okay, so midline abdominal tenderness is not a common feature. The abdominal tenderness should be on the side like iliac fossa. Okay, on both sides, either right iliac fossa or left iliac fossa. That's the site for fallopian tube. And greater than 8 week size means the ectopic pregnancy which is growing in the tube cannot reach that big size. Before that big size is reached, usually it is ruptured. So greater than 8 weeks means there is a less chance of ectopic pregnancy to occur. On pelvic examination, The uterus may be slightly enlarged and soft, and uterine or cervical motion tenderness may suggest peritoneal inflammation. We already talked about each of the point. So enlarged and soft uterus, but it is not that big, never as big as the normal pregnancy. Uterine or cervical motion tenderness may suggest peritoneal inflammation. An adnexal mass may be palpated, but is usually difficult to differentiate from the ipsilateral ovary, which is such a small one. So sometimes, it is just like as the size of the ovary. It is very difficult for us to differentiate whether this is a normal ovary or adnexal mass. But remember, if we combine different evidence together, then we can think about it. So what I mean here, if she is amenorrheic, okay, she just missed one period, urine pregnancy test is positive, then if I feel that mass, we may think, oh, this may be an adnexal mass rather than the ovary. So something like that. So always try to, link the evidence together. Never rely on only one evidence. That's how we reach to the clinical diagnosis. Now, let's move further. Please pay attention. What are the investigations we like to do in a case of ectopic pregnancy? Now, serum and urine assays for the beta subunit of human chorionic gonadotropin has to be done. This is to diagnose the pregnancy itself. We all know beta HCG is produced by syncytial trophoblast. Okay, syncytial trophoblast of trophoblastic tissue. Trophoblast will later on develop into placenta. So this beta HCG, if it is there, it will confirm that pregnancy is there. In a normal pregnancy, the beta HCG level doubles every 48 to 72 hours until it reaches 10,000 to 20,000 milli, international unit per ml. In ectopic pregnancy, the beta HCG level is usually increased less. Everyone, use their common sense here. It all depends on the size of the growth. In tubal pregnancy, the size will never reach that big, or the same amount of hormone synthesis will not occur. But hormone will be detected, like beta HCG in the blood or in the urine. According to Keder et al.'s study, this one study, is mentioned here, an increase in beta HCG of less than 66% would be associated with an abnormal intrauterine pregnancy or an extrauterine pregnancy. Now see there, this is a study which has confirmed this. Apart from normal intrauterine pregnancy, if there is abnormal intrauterine pregnancy, means maybe cervix, maybe in the corner of the uterus, maybe in the previous uterine scar, or an extrauterine pregnancy like this tubal pregnancy, abdominal pregnancy, or any other site, the increase in beta HCG level is less than 66% in comparison to the normal one. Means less amount of beta HCG is present in this situation. Let's move on. Now, another important type of investigation we have to do in time before this patient goes for surgery is blood type, RS type, and antibody screen, okay, which is done in all pregnant patients with bleeding to identify patient in need of a ROGAM and to ensure the availability of blood products in case of excessive blood loss. Now, what is ROGAM? Yes, what is that?
Sir, it is given as RH compatibility factor disease, sir.
Exactly.
It's a passive anti-D IgG antibodies.
Exactly. So ROGAM is anti-D antibody, and it is given in RH incompatibility case. Now see here also there is bleeding occurring. So we have to protect. We have to protect this particular lady, okay, against that RH incompatibility for the sake of future pregnancy. Probably for this, you cannot do anything, but for the sake of future pregnancy, we have to prevent the sensitization, and that is done by ROGAM. Now, she may need some blood transfusion. So this blood has to be ready in time. That's why every bleeding case, we need to know blood group and what is the RS type, isn't it? Then blood can be available. In women with normal baseline findings for liver function test and renal function test and complete blood count on day 1 of single or double dose methotrexate treatment for sonographically confirmed ectopic pregnancy. Now, please mute yourself. Now, later on, I'll teach you about the management, and methotrexate is one of the important drug here. That is medical management of ectopic pregnancy. And you all know methotrexate is a very powerful anti-metabolite. Okay, it is also a type of anti-cancer drug. It has a different side effect. One of the most important is bone marrow suppression. So we need to know what is the normal baseline complete blood count before we use methotrexate. What is the hemoglobin level of the patient? What is hematocrit? What is the total WBC, differential WBC, platelet count? We need to know that. Then only we can compare what damage that methotrexate has done as a side effect. Similarly, liver function test and renal function test value has to be there. Okay, then we can compare later on. This is not only done for methotrexate, but for any other powerful group of medicines. Now, let's talk about a discriminatory zone. Okay, this is a bit of a meaning here, so please pay attention. The discriminatory zone of beta HCG is the level above which a normal intrauterine pregnancy is reliably visualized. Once beta HCG has reached a level of 700 to 1000, okay, milli-intrauterine unit per ml, a gestational sac should be seen within the uterus on transvaginal ultrasonographic image. Now, this is a very important, information. See this. We first measure beta HCG in the urine or in the blood. Once it reaches this much level, then ultrasound should see a gestational sac inside the uterus. In case of ectopic pregnancy, there is no gestational sac inside the uterus. It is absent. Because it is not there, it is implanted ectopically. Once it has reached 6000, a gestational sac should be visualized within the uterus and abdominal scan image as well. The first one is a transvaginal ultrasound, which is much more sensitive. And later on, when the level is very high, even abdominal ultrasound can visualize the gestational sac. But in case of ectopic pregnancy, even if it reach this much, the gestational sac is not present inside the normal intrauterine site. Okay. Now, what is the role of progesterone level in the investigation of ectopic pregnancy? Why we go for the measurement of progesterone? Now, it's a bit similar to HCG actually, a bit similar. The amount of progesterone increase in this condition is not that high in comparison to the normal intrauterine pregnancy. Now see here. A single serum progesterone level is another tool that is useful in differentiating the abnormal gestation from healthy intrauterine pregnancy. In one large study they have done, a progesterone value of greater than 25 nanogram per ml excluded the ectopic pregnancy with 97.4% certainty. Furthermore, levels of 5 nanogram per ml or less indicated a non-viable pregnancy, ectopic pregnancy, or intrauterine, and excluded normal pregnancy with 100% sensitivity. Now, this is a bit of complicated, probably for you. So let me make it very simple. The important meaning here is the level of progesterone in this condition of ectopic pregnancy would be much lesser in comparison to the normal intrauterine pregnancy. Just remember that much. The level and things, all those things are not important at this level. Okay, if somebody asks you why progesterone is measured, you just answer like this: the level of progesterone would be much more less in ectopic pregnancy than in normal intrauterine pregnancy. But there are certain differential diagnoses, even in case of non-viable pregnancy. Okay, like the implantation has occurred, but the embryo is dead already, isn't it? Or other sites of intrauterine, like cervical one, the level of progesterone will also be less. Now, another investigation which we have already talked about is ultrasonography. There are different types of ultrasonography. One is done by transvaginal route, another is done by abdominal route. Visualization of an intrauterine sac with or without fetal cardiac activity is often adequate to exclude ectopic pregnancy. That clearly means this is normal intrauterine pregnancy. The exception to this is in cases of heterotopic pregnancy. Now, this is a very interesting and very rare case. Okay, heterotopic pregnancy means, see there, it's a combination of intrauterine and ectopic pregnancy together. Okay, and it may occur in approximately 1 in 30,000 cases. Now, this is a a bit rare, isn't it? 1 in 30,000. Now, in which situation it may occur? It is a bit like multiple pregnancy, which we have studied in obstetrics. Multiple pregnancy, because different implantations are there. One may occur in ectopic site, another in the normal area. It may occur in ovarian stimulation and assisted reproduction. So let me ask you one question now. Which drugs are given for ovarian stimulation? Which drugs are those?
Clomiphene citrate.
Another one? Yes. Clomiphene, absolutely. Yes, gonadotropin, exactly. Clomiphene and GnRH, okay, gonadotropin, different type of gonadotropin or GnRH are used for the ovarian stimulation. Clomiphene, of course, has to be the first one. And then assisted reproduction means in the last class of infertility, we talked about that. So we retrieve, ova or sperm from the husband and wife, and then we do all those, in vitro fertilization technique, and then the fertilized ovum is again, kept inside the uterine cavity. During that time, okay, the doctor thinks that if one fails, I need to have other as well, and sometimes, this has a high chance of multiple pregnancy. Now, what are the other type of investigation, and what are the other role of ultrasound? Let's finish ultrasound and let's go to the other investigation. The value of ultrasound is highlighted further by its ability to demonstrate the free fluid in the cul-de-sac area. Now, what is cul-de-sac? What is another name for cul-de-sac?
Pouch of Douglas.
Exactly. Absolutely right. Pouch of Douglas. Now, pouch of Douglas is present between which two structures?
Between the rectum and the uterus.
Exactly. Is absolutely correct. It is also known as uterine pouch of Douglas. Recto-uterine pouch of Douglas or pouch of Douglas only are called the sac. It is considered as the deepest cavity or sac in the abdominal cavity. It's a part of pelvic cavity, of course. So if there is a rupture of ectopic pregnancy, then the blood will collect there, and it can be detected by ultrasound. However, although free fluid can represent hemoperitoneum, it is not specific for ruptured ectopic pregnancy. It may be collected there because of some other reason, but let's combine all the clinical features together, So if everything is matching with ectopic pregnancy, then this has to be the rupture. This is how we synthesize our diagnosis. Yes, if there is no history of a missing period, if beta HCG level is not high, then probably this collection of the blood may be because of some abdominal pathology. But in this case, all the pieces are there. Okay, so this is how we reach to the diagnosis here. Free fluid on ultrasonographic image can represent physiological peritoneal fluid or blood from retrograde menstruation and unruptured ectopic pregnancy as well. So these are some of the differential diagnoses of that fluid from where it comes. See this. Peritoneal cavity has got certain amount of fluid. It may be that, but that level is very less. Or sometimes blood collection occurs from retrograde menstruation. Now this is a bit of interesting situation. Retrograde menstruation is a feature of endometriosis. Endometriosis. In normal situation, it doesn't happen, but in situation known as endometriosis, where there is a presence of ectopic endometrial tissue, they also bleed along with the hormonal changes at the end of the month, and wherever they are present, okay, then bleeding can collect there. That is our next topic after I do ectopic pregnancy. Now, another type of investigation, it's a type of ultrasound itself, is transvaginal or endovaginal ultrasound. So I'm not going to talk a lot about this. This is just a modality of ultrasound, but this is far more sensitive way than the abdominal ultrasound. Okay, far more sensitive one. So according to this type of ultrasound, we have got presumed ectopic pregnancy and definite ectopic pregnancy. Now, how we reach to these diagnoses. An empty uterus, an endovaginal ultrasonographic image in patient with a serum beta HCG level greater than the discriminatory cutoff value, which we talked before, is an ectopic pregnancy until proven otherwise. Okay. So see this, all the points are coming together. An empty uterus may also represent a recent abortion though. In this situation, the uterus is empty, but that can happen because of recent abortion. Now, can you tell me what are the types of abortion? What are the types?
Spontaneous abortion, induced abortion, threatened abortion, incomplete abortion, complete abortion. Sir.
Good. Very good. So now another question, out of that, in which there is empty uterus? In which there is empty uterus?
Complete abortion, sir.
Complete abortion.
Very nice. Complete abortion. Excellent. So you have to clearly understand here, in case of threatened abortion, okay, the cervical opening is not open till now. So whatever content is there is still inside the intrauterine cavity. Incomplete means some of the thing is still there, and complete abortion means it is empty. It is empty. Okay, so it may be confused with that. So we need to think about, but there are certain other features there. It is not a difficult diagnosis. Definite ectopic pregnancy because of transvaginal or endovaginal ultrasound, okay, means in the presence of definite ectopic pregnancy, a thick, brightly echogenic ring-like structure is located outside the uterus with a gestational sac containing an obvious fetal pole, a yolk sac, or both. So this is a real, embryo there, and this is an unusual finding, because if it is occurring outside the intrauterine cavity, mainly in the fallopian tube, this is a definite diagnosis of ectopic pregnancy. Definite. Then we have to go for the management. Now, another type of investigation, okay, is called cordosynthesis. Now see this. Cordosynthesis. cordosynthesis. Now, the name itself suggests its meaning. So, what is the meaning of cordosynthesis? See there? Yes. What may be the meaning? Just like thoracosynthesis, just like pericardiocentesis. Yes.
Sir, aspiration.
Aspiration from the coldest section.
Sir.
Exactly. Aspiration, okay, from cul-de-sac or pouch of Douglas. Whatever content is collected there, we try to aspirate it out and observe it or examine it. That is called cordosynthesis. So cordosynthesis is another rapid and inexpensive method of evaluation for ruptured ectopic pregnancy. It is performed by inserting a needle through the posterior fornix of the vagina into the cul-de-sac and attempting to aspirating the blood. When non-clotting blood is found in conjunction with the suspected ectopic pregnancy, operative intervention is indicated because the likelihood of a ruptured pregnancy is high. So simple meaning is, on aspiration, if blood is aspirated out with other features of ectopic pregnancy there, it has to be the rupture. Then we have to go for proper management. Now, another important type of investigation is called laparoscopy. This laparoscopy can be diagnostic or can be therapeutic as well. Okay. Diagnostic as well as therapeutic. Now see here. Patients who are in pain or those patients who are hemodynamically unstable. See there. Unstable should proceed to laparoscopy. Now, this is a very important clinical term. What do you mean by the term hemodynamically unstable? Can anyone explain to me what is the meaning of this?
Sir, it means if there is any hypertension or hypotension, or if there is any low blood volume and if high blood volume, it means there is no proper hemostatic level of the circulation, sir.
Okay, good, good. Anybody else? Very nice, nicely explained.
Hemodynamically unstable may be an hypovolemic tachycardia. All signs of hypovolemia are there because
Good.
of rupture.
Good, good, good. Now see here, both of them are correct. Hemodynamically unstable means there probably is hypovolemic situation now, hypovolemia. And in case of hypovolemia, the indirect marker we are going to examine in the patient, and those are pulse. We examine pulse, we examine blood pressure, and we examine certain other indicator in the patient. So regarding the pulse, it would be tachycardic and low volume. Tachycardic and low volume. Regarding the blood pressure, in the earlier situation, it may be normal, but in the later, when there is excessive bleeding, it should fall. These two are the most important criteria for hemodynamically unstable patient in this case. Okay. Now, some other features of severe hypovolemia may be there, like prolonged capillary refill time, prolonged more than 2 seconds, isn't it? The person may look pale, the lady may look pale. Another one, okay, she may be sweaty, that is called diaphoresis. Diaphoresis, this is a feature of sympathetic stimulation. And when I feel her palms, okay, and soles, they may be excessively cold and they may be clammy. Clammy means they are wet because of excessive sweat. All of these are the features of hypovolemia, and that is the meaning of hemodynamically unstable in this case. That means the ectopic pregnancy is ruptured, so they should proceed to laparoscopy and then proper management. Laparoscopy allows assessment of the pelvic structure, the size, and exact location of the ectopic pregnancy. So this is the diagnostic one, diagnostic type of laparoscopy. The presence of hemoperitoneum and the presence of other conditions such as ovarian cyst, and even endometriosis, when present with an intrauterine pregnancy, can mimic an ectopic pregnancy. So these are the differential diagnosis of ectopic pregnancy, and they also can be ruled out. Now, why they are considered as a differential diagnosis? Just think about it. Okay, just think. Endometriosis also can bleed. It can also lead to presence of the blood in cul-de-sac. It can also lead to abdominal pain. Though there is no raise in beta HCG level, but some clinical features are matching, so it can be considered. Ovarian cyst rupture is another one. There will be severe pain on one side of the abdomen, especially one iliac fossa. Okay, and there may be features of intraperitoneal bleed as well. So laparoscopy is a wonderful type of investigation in this situation. Now, with this, investigation and with all those symptoms and signs, we have confirmed the diagnosis of ectopic pregnancy. Now, let's move on to the management part. In case of ruptured ectopic, okay, the diagnosis of ruptured ectopic pregnancy is suggested by these things together. So see this, every student should know that now. History of amenorrhea has to be the first one. Vaginal bleeding and abdominal pain in the presence of hemodynamically unstable patient. These all things together is suggestive of ruptured ectopic pregnancy. Now, what is the management? Immediate surgical intervention is necessary to stop the bleeding. Okay, for that, we need to take the lady for immediate laparotomy. But before the laparotomy, we need to resuscitate her. There's a quick resuscitation. A lot of crystalloids should be given, and if necessary, blood should be ready, and blood transfusion is usually done during the surgery or operation. Now, what we do, if we are lucky and if we have diagnosed her in unruptured state, management can be medical with methotrexate or surgical with laparoscopy in case of unruptured ectopic pregnancy. Now see here, medical treatment is preferable because of the lower cost with similar outcome, okay, like a surgical one. Remember, this is unruptured ectopic. There is no real danger to the life of the lady at present, okay? At present, I'm talking about, because it is unruptured. So we can take a bit of time and decide which is the best treatment for her. So in this situation, medical treatment is preferable. And methotrexate is the drug which is used for this purpose. Methotrexate is a folate antagonist drug. Okay, so it attacks rapidly proliferating tissue in our body, including trophoblastic villi. As a result of this common mechanism, a lot of side effects are there when we use methotrexate. All those rapidly dividing tissues can be destroyed. Now, can you give me some examples of those rapidly dividing tissues in our body? Where are they present?
Sir, our hair cells and our GIT tracts and epithelial cells.
And one more. Very good. One more. Bone marrow, isn't it?
Bone marrow, sir.
Very good. So most of the example he has already given in this situation, in these areas, like in bone marrow, those stem cells of the bone marrow, the hair cells, epithelial cells in any part of our body. Okay, all of these, along with these trophoblastic cells or villi or tissues, they are also rapidly proliferating tissue. So all of them can be damaged by methotrexate, and that can lead to a lot of side effect. Criteria for use of the methotrexate are pregnancy mass less than 3.5 centimeter diameter, not that very big, absence of fetal heart motion, beta HCG level less than 6,000, and there is no history of folate supplementation in the patient, because it's a folate antagonist drug, and if we supplement folate, probably they may antagonize each other and the effect is not that proper. So this is one of the things, and other are very easy to understand. All of these are met by ectopic pregnancy. Now, patients with an ectopic pregnancy should be advised of the somewhat increased incidence of recurrent ectopic pregnancy in the future. We have studied this right in the beginning of this topic in epidemiology. Once ectopic pregnancy occur, there may be a chance of recurrence in the future. So we need to, at least warn them regarding that. Follow-up is done with serial beta HCG level. Okay, it's crucial to ensure the pregnancy resolution completely. After the use of methotrexate, the beta HCG level should gradually decrease and disappear. And RS negative woman should be administered ROGAM. I already talked about that. So this is known as medical management of ectopic pregnancy. Now, we're talking about the management of ectopic pregnancy, whether they are ruptured or unruptured. Ruptured ectopic pregnancy is mainly managed by laparotomy. We open the peritoneal cavity and then we manage accordingly. But it can also be managed by laparoscopic surgery. Okay, it depends on how expert the surgeon is for the use of laparoscope. In both ways, the ruptured ectopic pregnancy can be handled. But if it is a bit of complicated case, isn't it? If patient is hemodynamically unstable and things like that, probably a laparotomy is more preferred over laparoscopy because we have a wide field of vision in case of laparotomy. Now see there, laparoscopy, okay, can be done for the management of unruptured ectopic pregnancy quite commonly, and the thing which they do is salpingostomy. Salpingostomy. So they don't remove the tube, means fallopian tube there. They just give one of the cut, and then the trophoblastic villi are dissected free, preserving the oviduct or fallopian tube. This is salpingostomy. It is done in unruptured ambulatory type of tubal pregnancy, which is the most common one. So remember the term salpingostomy. Here, they are not cutting, they are not excising any fallopian tube. They just give a cut on the surface, and through that, the trophoblastic villi of the embryo is taken out. Whereas, in case of isthmic type of tubal pregnancy, isthmus of the fallopian tube, they are managed with a segmental resection in which the tubal segment containing the pregnancy is resected. So there's a slight difference there. Let's move on. Now, what about in the ruptured one? If the ectopic pregnancy is already ruptured, in case of tubal pregnancy, then we can remove the fallopian tube. That is known as salpingectomy, removal of the fallopian tube. It is also reserved for the patient who doesn't have any desire for further fertility. If they have completed, for example, they already have 1 or 2 babies, and when we are taking the consent, we have to properly explain the fallopian tube is ruptured. What should I do? Then, if they give consent, then only we can go for this. Okay, they have no desire for further fertility. If the lady cannot answer during the time, then husband can give the consent. So this is the way. Sometimes she is so much hypovolemic that probably she's unconscious or something like that. But the best one is consent taken from the patient herself, and she doesn't need to take consent from the family. From the legal perspective, I'm talking about it, but for the sake of the family, value or family pressure and things like that, it is better she consult the family. But it is her own health, own life. She can decide whatever she wants to do. Okay, if she doesn't want the further fertility, she can give consent for salpingectomy. And that is always better in this ruptured ectopic pregnancy because there is no extra pressure for the surgeon to shape the fallopian tube. After a salpingostomy, beta-HCG titers should be obtained on a weekly basis to make sure that there is resolution of the pregnancy. This is another important point. Sorry, see that? This is called follow-up. Beta-HCG titers should be obtained on a weekly basis to make sure that there is resolution of the pregnancy. An Rh negative woman should be administered Rhodium for the sake of future pregnancy, not for this one, for the sake of future. Now, for regarding the follow-up, the same thing again. Patients who are treated with salpingostomy should be followed up with beta-HCG to assure there has been complete resolution of the pregnancy. Once salpingectomy is done, probably you don't need to follow up with beta-HCG because everything has been removed there. It is just like a removal of the affected organ, just like in malignancy. You can compare it like that. But in salpingostomy, the fallopian tube is still there. We have only removed the affected, disease. We talk like that. So we need to go for the proper follow-up. So this all about the discussion in ectopic pregnancy.